Right then, I think we'll get started. So I'm really pleased to introduce everyone to Dr Sam Waterman. She's a clinical psychologist for the Buckinghamshire NHS Trust. I'm really grateful to you for giving up your time tonight. Obviously it's late and I know you've had a busy day at work, so thanks ever so much for doing this. It's a topic we're really looking forward to covering. It's something we get asked lots about. Dr Waterman's going to cover how psychology support can be involved in PoTS care and the different ways it can complement physical health interventions. So the format will be a presentation with some slides, and then there'll be an opportunity to ask questions at the end. Please feel free throughout the presentation to pop your questions into the Q&A box. We'll cover those at the end. Dependent on how we're doing for time, we'll if we don't get the chance to answer them all, we'll always try and cover those and pick them up after the event, so hopefully nobody will get missed. We'll be able to share the slides with you afterwards if anybody would like them, and it will go up onto our YouTube channel as well in a couple of days, so anybody that's missed it that wanted to attend will have the opportunity to catch up, or if you're feeling a bit fatigued and you can't last for the whole session, then that's absolutely fine because you'll be able to catch up. So I will hand over now to Dr Waterman, and thank you very much again for giving up your time. It's lovely to see you.
Thank you for having me. I'm going to try and get my slideshow up, so just give me 2 seconds and make sure that I can actually do that.
I just thought we were so busy chatting, weren't we, that we didn't actually practice sharing the slides.
That's fine. Absolutely fine.
Fingers crossed, everyone.
Okay. Can everyone see that? Or Joe, can you see it?
I can. Yeah, it looks perfect.
Okay. So can you see the proper version, not the presenter version? Yeah.
Yeah, I can see it as it should be.
Just the slideshow. Lovely, thank you. So as Joe said, I'm Sam. I'm a clinical psychologist, and I work in health. So in my NHS role, I work in a neurological rehabilitation service. So I work with people who have long-term degenerative, usually neurological conditions, and people who have had strokes. And then I have a small private practice where I work with people with other long-term health conditions. So my specialty is mainly in sort of health-related stuff. And I recently did some research into experiences of living with PoTS. So if you're at the retreat, you might recognise me from that. And that's how I got involved with the charity. So I thought I'd start with this to make it very clear at the beginning. PoTS is not a mental health condition. And I'm acutely aware that because of the often long and drawn out and complicated diagnosis journey many people with PoTS have been on, which unfortunately we know frequently includes misdiagnoses with anxiety or panic or other psychological conditions, hearing psychologist mentioned in this space can make people really nervous. I'm hoping to show the different roles that we can play and why psychology support is helpful alongside physical health interventions. I know sometimes people can feel uncomfortable because they don't see psychologists around other conditions, and they worry that that's implying PoTS is more psychological than other conditions, and it really doesn't mean that. It just means the rest of the medical world hasn't caught up a little bit, and I think it's something that is changing over time, but I know it's something that people still get worried about. And I say that in a PoTS talk, but it's something I face most days at work. When I see new clients at work, I get lots of people being like, why am I seeing you? Like, I've got a neurological condition, you're a psychologist. So hopefully this talk can share a little bit about why I think we can be helpful alongside doctors and alongside all the physical health stuff that you're doing. So although PoTS isn't a mental health condition, it is distinct from anxiety and depression. It can negatively impact on many areas that we know can compromise your mental health. So things like sleep and mobility, appetite. It can impact on your ability to engage in activities. It can impact on relationships. So all of these things can actually affect your mental health, and they can also make your usual coping strategies less accessible. So we kind of need psychologists around, even though we're not saying it's not a mental health condition. And we'll come back to this shortly, but experiencing things like anxiety and depression are really common alongside long-term conditions. So there's about 16.5 million people in England that have a long-term health condition, and about 4.5 million of those are going to have psychological distress alongside it, which is about 30%, so it's not small. And people with long-term conditions in general are more likely to experience mental health difficulties, and that increases ever more with 2 or more long-term conditions present. And we unfortunately know with PoTS, there's often other comorbidities, so PoTS is often not the only condition that you're managing. So that's my caveat to start. It's not a mental health condition, but this is my sell for why I think psychologists are still important. This slide is missing my picture. Oh. Well, I'm just going to talk through it, but bear with me for a very brief foray into some theory. So the biopsychosocial model, which is a complete mouthful, is a model of well-being, and it suggests that biological, psychological, and social processes are all integrally and interactively involved in physical health and illness. And there's long been this sort of dichotomy, particularly in the medical world, between your mind and your body, and keeping them quite separate, that they're ill at different times. And actually that's slowly changing, and we're realizing that there's a huge link between the two of them, which is a really positive thing. And this model, and my usually beautiful picture of it was all like circles crossing over it. You'll see it if you get the slides, but it demonstrates the connections between those 3 areas. And it's not linear and unidirectional. It's not that a physical illness causes psychological and social difficulties. And it's not that psychological factors cause physical illness, which is a model that is overused, I would say, and it's got some uncomfortable and often very unhelpful labels with it, such as psychosomatic and somatization. But this model kind of suggests that it's a non-linear understanding of the really normal interaction between biological processes, psychological processes, and social factors. So that's kind of the center of where I work from, and most psychologists that work in health come from. And our mind and body and emotions are intricately linked, and they constantly influence each other. So if you just take a quick minute to have a look at these different phenomena and just think about if you've ever experienced any of these, because these demonstrate the everyday interplay between our mind, our body, and our emotions. So for me, I am very good at blushing when I am embarrassed or nervous or in any situation where the attention's on me. You can probably see right now my cheeks are bright red. Throughout this talk, my ears are probably going to get a lot redder. It's just something that I know my body does in response to feeling slightly nervous. Other ones are really common, so that kind of sweating and nervousness, butterflies in the tummy before an exam, feeling exhausted after an argument. I often have clients be like, I was just knackered, but I don't understand why, because I was just yelling. And actually, it's those emotions affecting your body. And the same is true with physical health conditions. So the condition can have a significant impact on our emotions and our mind. And similarly, the way that we're feeling can have a big impact on our physical health condition, whether that's directly increasing the symptoms or decreasing the symptoms, or by affecting how able we are to cope with the symptoms at any point in time. So sometimes if our emotional capacity is really overloaded, physically, we just can't manage in the same way. And if we don't address the emotional sort of psychological aspect of this, we tend to end up in a tricky situation. So I'm going to go through a drawing that I go through with most clients. I'm not an artistic person. I'm very not creative, but I love writing down what I'm trying to get across. So we're going to run with it. But we often have, oh, these aren't coming up either. Weird.
They were showing, when I looked at your slides, they were showing. So
right, we'll pause and I'm going to see if I can find them, if that's okay.
Yeah, absolutely. Because they absolutely were coming through. Are you on a Mac?
I'm not. How weird. I'll reopen it. Sorry, everyone.
It's a lovely drawing. It's worth waiting for.
Really not. Let's see if this works. Ah, this looks like it's going to work. Okay. Can you see it now?
Yes.
Yay. Okay.
Well done. Very calm under pressure there.
I'm redder, don't worry. My body's giving me away. Okay, so pushing feelings away is kind of like pushing a ball underwater. So if you've ever been on holiday and you've had one of those inflatable beach balls and you've tried to push it underwater, I know as a kid I used to try and jump on it. That's a similar thing to if we try and kind of push our feelings away. And it might work to begin with. They kind of disappear, they go outside, the ball gets under the water, they might get close to being out of mind. But after a while, you tend to notice that actually that's taking up a lot of your energy. That's taking up a lot of effort. And if you're someone who has limited energy and limited resources, that's taking up a lot of energy you could be spending elsewhere. However, as soon as you stop at spending that effort, we tend to find that the feelings come rushing back to the surface and they can feel bigger than ever and they can feel more overwhelming, because just like if you're holding that ball under and you let go, it flies back up at you. It's exactly the same thing happens with our emotions. And because of that link we were talking about with our emotions and our body, we can sometimes find that that overwhelming wave of emotions can mean we have an overwhelming wave of symptoms as well. So through addressing the emotional and psychological side of things that contribute to our well-being, we're hoping to get to a place where we can let the emotions be around when they show up, because we can live more easily with them when we allow them to have some space. And I always start my therapy with clients with this, because this is also the aim that we tend to be working towards in therapy, getting to a place where your emotions are still there. We're not trying to make them leave or distract us from them, but they just have their own space and they can be. Often we say kind of feeling is healing. Having those emotions around, although it can be difficult, is a really important thing. So we're just going to have a quick tour of different difficulties people may experience alongside PoTS. I should have said that psychologists get involved in, because I know there's a whole host of stuff people experience that is way out of my wheelhouse. But these are the things that psychologists look at. And as a quick caveat, there's sort of two things that psychologists concern themselves with. The one that everyone tends to know about is people's emotional well-being and your mental health, so the stuff we've talked about so far. But the other side of our role is looking at people's what we call cognition, so their thinking skills. And both of these things can be affected by PoTS. So I thought I'd start with the cognitive side of things. So people with PoTS often report changes in their cognition, so changes in their thinking skills. And the most commonly reported ones are changes in attention and concentration, so brain fog would usually come under that category, as well as changes in memory and particularly short-term memory. And people often report these difficulties occur when they're standing, so when lots of PoTS symptoms come, but actually also people notice that it happens when they're sitting, and it happens kind of more pervasively throughout the rest of the time. There have been mixed findings in the research about this. It's of note that there is really not a whole lot of good quality studies in this field, as it is anyway. But in those that have been reported, there's really significant variation in study design, particularly whether or not they test people under orthostatic stress, so when they're standing and when they're sitting, or if they just test people when they're sitting. So it's not totally clear what cognitive changes are associated with PoTS and whether these are only seen under orthostatic stress or more broadly. It's something that is being worked on. But generally, and I say this very generally, of the published studies that are available, they suggest that changes may occur in working memory. So that's our ability to hold and manipulate information. Verbal memory, so being able to listen to something, take it in, remember it, recall it later. Attention, that's ability to attend. Attention is what we call sort of the foundation of cognition. If you picture your cognition like a pyramid, attention sits right at the bottom. So we know in conditions that affect attention, that can then have a sort of knock-on effect to other areas of your thinking skills, because your attention is very important right at the bottom. We also see difficulties in processing speed, so people feeling that their processing speed has slowed and they're not able to process information as quickly as they could before. And also executive function, which is a very broad term for basically what your frontal lobe does, and maybe your temporal lobe a bit, but it's things like decision making and problem solving and sequencing, all of that sort of more complicated cognitive stuff. And the studies that apply orthostatic stress, so the ones that test people when they're standing, they have generally found cognitive difficulties when that stress is applied. So even if the person that they're testing can remain unimpaired when they're sitting, they've generally found that when they raise them up, if they've got PoTS, the cognitive difficulties are evident there. It is important still that we acknowledge that even if you're not finding objective changes, if someone is subjectively reporting difficulties to you, that means that that's likely still having an impact on their life. So as psychologists, it's something we always consider, and we can still think about strategies for managing those difficulties, even outside of having objective difficulties sort of proven on a test. Okay, so moving now a little bit more to the other side of psychology role and the mental health. I'll start with anxiety. It's usually the most common one, and the relationship between PoTS and anxiety is very complex. So many symptoms of anxiety, such as palpitations and sweating, are mediated by the autonomic nervous system, which we know is very involved in PoTS. And previous research has suggested that there's an overlap in the central mechanism for both panic disorder and PoTS. So both of them involve our noradrenergic system, which might explain why there's such a crossover. But this can make it very difficult to differentiate between PoTS and anxiety when seeking a diagnosis initially. That's not to say it's okay that lots of people are diagnosed with anxiety when they have PoTS, but it hopefully explains a little bit about why that sometimes happens. But what it can also do is make it difficult for someone who has been diagnosed with PoTS to disentangle when they may be experiencing anxiety versus a flare-up of their PoTS symptoms due to that really significant crossover. And I know I've had sometimes people say, I'm physically feeling very anxious, so I'm having that kind of butterflies in my tummy, I'm a bit shivery, I'm sweating, I'm physically feeling anxious, but cognitively I can't think what's making me anxious. So that can be really tricky when it feels like your body's telling you need to be worrying about something, and actually at that point your mind isn't worried about something. And if you're someone that's going through therapy for anxiety, it can be really important to try and spend some time untangling those two a little to understand what's driving and what's maintaining that distress. Is it PoTS? Is it anxiety? So is this a process that's going on in my mind, or is this my body doing something? And like I said, it's tricky because the process in your mind will trigger the body. So it's something to spend time disentangling. It's been debated, I would say, in the literature whether people with PoTS have an increased prevalence for anxiety. Some studies say they do, some studies say they don't. And I'll probably say this loads of times through the talk, and I know I said it loads of times when I talk about my research, but this is a really under-researched area. So it isn't an area we sort of confidently know one way or the other. But a review that was specifically looking at PoTS found this population seemed to have a slightly higher prevalence of anxiety compared to the general population, but it was significantly less than a panic disorder population. And they specifically noted that the anxiety these people experienced in the PoTS group might be distinct, and it's often driven by somatic vigilance and orthostatic symptoms. So that cycle I said earlier, where your body's feeling anxious and it can trigger you to then worry about that. So it's a bit different from what we often see in panic disorder, where it can be thoughts that people are having that really triggers that physical response. And then relatedly, studies have found a higher prevalence of anxiety disorders in people who experience recurrent episodes of fainting. And that's been found in PoTS and other orthostatic conditions that cause fainting, which makes sense. If you're fainting, it's something that can feel really sudden and really scary, and it can come out of the blue. And sometimes people develop anxiety around that happening. So just thinking a little bit about low mood and the association between low mood or depression and chronic illness more broadly has been very well documented. And it's particularly common where a person has more than one condition. And as we know, that can be quite frequent in PoTS with the many comorbidities that come alongside it. One thing we know contributes to depression is feeling misunderstood and feeling isolated. And this can be quite common if people are seeking a diagnosis of PoTS and they're finding that they're going to doctors and not being understood, or they're speaking to their friends and they're not being understood. And the isolation that can come both during the diagnosis process and after, when you're struggling with symptoms that people maybe don't understand or can't see, we know that that can contribute to low mood. PoTS is also associated with cognitive difficulties, like I said, But low mood is also associated with cognitive difficulties. So if you've got two conditions, there's that real interplay between what's causing the low mood, what's causing cognitive difficulties, and all of that together can increase the functional disability that that person's experiencing. And PoTS can sort of physically distance people from previous coping strategies. So particularly ones that involve physical exertion. I know for a lot of people, before they develop conditions that can prevent this, running and exercise can be really good forms of managing your mood. And it's something that you often hear in the media, kind of, oh, run for your well-being, run for your mood. And exercise is often pushed as something to help people's mood, and it works. It fills you with endorphins, and it's a really good thing. When you have a condition that prevents you from being able to engage in that way, it can be really tricky. And it's not exclusively physical difficulties. I know cognitive changes and comorbidities like migraine can really affect engaging in less physical activities as well. So this kind of withdrawal from activities can reduce people's mood, but it also means you're not able to rely on strategies that previously you may have used to manage your mood and your well-being. And then this is a big one, and it's often talked about less generally, I think, but many people with PoTS describe feeling a sense of grief about the changes that have come as a result of their condition. And grief is something that can feel all-consuming, both mentally and physically. And it doesn't just come with the traditional sense of loss, but it comes and can come often after a new medical diagnosis or a change in your health status, and the subsequent kind of shift in identity and in your life that can occur as a result of that. People sometimes talk about kind of grieving the loss of a healthy body and processing that loss and the change to the life that you previously saw for yourself. And that can take time and space to work through. And it's okay that it takes time and space to work through. As we mentioned on the previous slide, you can find you're not able to do everything you did before. And so people mourn the loss of activities and experiences that aren't necessarily compatible with their current health situation. And again, this is magnified if that was something you used to manage your mental well-being. For example, if you were a runner and now you can't do that. Sometimes people even speak about grieving the loss of spontaneity and the loss of freedom that can sometimes happen with a chronic illness, whether that's from having to take medication at certain times or having to restrict your diet. A lot of restrictions can come along with these conditions, and that can be really difficult to manage. Chronic sorrow is a term that you might have heard that gets thrown around in the media quite a bit, and it's used in the literature to describe this sort of longer term but periodic sadness that people with chronic illness can experience, and the sort of continual or cyclical losses that can come from a condition that fluctuates and changes. And grief cycles through different stages at different times. It's not linear. So this, again, my poor drawing, but this diagram sort of illustrates that. So many people will be familiar with the 5 stages of grief model, and that's totally applicable and it's useful, but this is a model that's been adapted a little bit from that. And this was adapted specifically for chronic illness. So the psychologist that adapted it included these 2 additional stages that felt relevant for this population. So the first is, after anxiety and depression, is that loss of self and confusion. And actually, this came up a lot in our recent research study looking at the experiences of living with PoTS, but people talking about losing their sense of identity and feeling separate from who they were sort of before and who they are now. And that shift can be really difficult to internalize and be able to move alongside going forwards. And the other one is the reevaluation of life roles and goals. And that's, again, related to what we said before, kind of mourning a life that you imagined for yourself, if it might look a bit different now. And this, again, can be difficult to work through. Hopefully this diagram gets this across, that this process is almost never linear. So you can cycle back and forth between the different stages. And that is important to know, that that's not going backwards. You can't go backwards with this model. It's just a process that you're moving through. It happens at your own pace. It changes. So I know people that I work with a lot, if they have a big flare up or a progression in their symptoms, they can find themselves spinning back through the cycle in a different way. and going back to stages of kind of denial and pleading, and they feel like they're taking steps backwards, but it's not. It's a cycle that you're working through, and it's important to remember that you can move in different stages at different times, but that doesn't mean you're taking steps backwards. So this is just a diagram that kind of talks through how we process grief following a medical diagnosis. So if we start, this is you before PoTS. And for some people, this is a really clear distinction. So if your PoTS was triggered by a viral illness or something, you might have a very clear idea in your mind of there's a me before PoTS and there's a me after. For other people, it's a bit more blurry. They might have been having symptoms for a long time, but we're just imagining this is the you from before. And you go through the process of all your medical investigations. That often takes time. And then you're given a diagnosis of PoTS. And often at this point, it can feel like the diagnosis and the condition are all encompassing. So they're that green circle, they're all around you. It can feel like it's affecting every area of your life, everyone around you, everything you do and look and think, it's all about PoTS. And often at this point, it's a bit overwhelming. And you may not at that point have the skills to manage it because you've just got the diagnosis, you've just found what this is, and you're starting on that road to learning what you can do to help. And then you move a ways down that road and you start to get some support in different ways to manage the condition, some medical intervention, maybe lots of lifestyle stuff. You maybe reach out to some support groups, you meet other people with PoTS. And over time, gradually, the PoTS becomes less all-encompassing and it's more something that you're carrying around with you. It's more manageable. That isn't to say it ever feels manageable and it ever feels, oh yeah, this is fine, I'm totally cool with this. That's okay. It doesn't need to feel like that. It doesn't need to go away because we know it's not going to. It's still there, but it's just a little bit easier to carry and it's not taking up everything and all around you. And as with the cycle before, we know this isn't a linear process. So you can cycle and oscillate back and forth between this overwhelming and then being able to carry it. And it can depend on a whole host of different factors. Again, if we go back to that biopsychosocial model, there's loads of different things that can be influencing it, whether it's a flare-up or actually just socially, you've got lots of stuff going on, you're really stressed at work and suddenly it feels like you're noticing your symptoms all the time. So again, this isn't that you're going back and forth in a bad way, it's just the process that you're moving through. But it can be important to try and recognize when you're moving from I can carry this to this is overwhelming me, and reaching out for support so that you can get help from others to get back to a place where it feels more manageable, whether that's support from a psychologist, professional support from friends, from family, from support groups. There's lots of different places that can make it easier to carry, but it's just recognizing when you might be getting back to that place that it's taking over and how you can get yourself help. Speaking of help, how can psychology help? Because I realize I've talked about all the different things that can be present and not so much what my profession does. So there's lots of different things and I'll do kind of a whistle-stop tour between them. And then I've got a couple more slides about specific things that I find helpful with people that I work with. I was very aware and keen when I started writing this to not make this a therapy session. I have a terrible habit of accidentally doing that when I do presentations, and I don't want to, mainly because therapy is so personal and it needs to be very tailored to you, particularly with chronic illness. There's really specific things everyone will be facing, and working with a therapist makes it perfect for you. But having said that, I'll go through some strategies. So one thing is strategies to scaffold cognitive change. And I'm actually not sure how common or easily accessible it is to have a cognitive assessment on the NHS for PoTS. So we do them in our service quite a lot, but that's a neurological condition, so it's a little bit different. But you could potentially do it privately if you wanted to. But it's basically just working with psychologists on understanding the difficulties. So when I do them, it's usually how can we understand someone's strengths and difficulties, and how can we use your strengths to scaffold the difficulties. So using the stuff that you're still managing well with to help scaffold the areas that you're finding more difficult. I've put management of symptoms. What I actually mean by that, I think, is management of symptoms. So PoTS can cause some really scary and uncomfortable symptoms, and there's a really fine line between needing to be vigilant of that so we don't get to the place where we're burning out or doing too much or being at risk of fainting and hurting ourselves, and then not becoming hypervigilant of symptoms so that it's really all-consuming and it's all you can think about, and that distracts you from doing things that you enjoy and going out and doing other stuff. So that's something that cognitive behavioral therapy and other forms of that type of therapy can be really helpful with. So it's not really management of symptoms, but it's management of symptoms, if that makes sense. And the types of therapy, so cognitive behavioral therapy, and also what we call third wave therapies, so therapies that have developed from that, such as acceptance and commitment therapy and compassion focused therapy, which are the two that I practice probably the most. They can help with sort of managing that balance between the two and making sure that although it's important to keep an eye on symptoms, it's not trickling into actually I'm really hypervigilant and this is taking over. They can also help manage thoughts that might appear when experiencing difficult symptoms. So for example, sometimes if you experience heart palpitations, you can get that kind of thought that comes rushing into your mind that something serious is wrong and you need to be in hospital and you might be at risk of a heart attack or something like that. And those thoughts can be really, really scary. And we know that then they can trigger the symptoms to get worse. So working on ways to sort of manage those thoughts a little bit and recognize what's going on. Equally, sometimes experiencing worries about having a big flare up and potentially fainting as soon as you notice symptoms kicking in. Psychological support can also help manage some triggers. I've said some because I totally appreciate it won't be able to help with everything, but particularly things like stress. So long-term stress negatively impacts anyone's health, but we know stress can often be a trigger for people with PoTS and it can exacerbate symptoms. So people sometimes notice if they're at a really stressful point in their life, their symptoms will be feeling worse a lot of the time. Similarly, with things like migraine, stress can be a really big trigger for migraine. So helping manage things like that. And we know it's generally not feasible to exclude all stress from life. Life is really, really stressful. So it's about helping manage how we respond to that stress and also just talking it out. If we go back to the diagram with the pushing the feelings down, if you're feeling stressed and you kind of shove it away, it tends to find its own way back, whether that's through your body and through causing symptoms or through your mind and it starting to be a real difficult thing that you're grappling with. Adjustment and acceptance is a really big one, I think. Processing the grief that we talked about and finding ways to be able to live alongside your condition is really important. And I think this is the bit of why psychologists are important that I really strongly believe in. I think sometimes it can sort of be brushed over. And there was a brilliant quote from our research that someone said, actually, just because PoTS doesn't kill you doesn't mean it's easy to live with. And I think that's one of the biggest things. I know sometimes people can feel really dismissed because they're like, well, it's not life-threatening, so you're okay. And you can't really see it a lot of the time, so you're probably fine. And actually, it is a really difficult thing to adjust to, and it can have such a huge impact on people's lives. So having the space to process what that's like and being able to get to a place of acceptance, and acceptance in therapy language, if I'm going to call it that, isn't you have to accept PoTS, you have to accept that this is your lot and that's it and you're done with it and you're resigning yourself to it. Acceptance, when we talk about it in this space, is more about a willingness to sit with the difficult feelings that brings. So it's, I mean, I've been working in health psychology for a while. I work with people with lots of different health conditions, and I've never met someone that gets to a point when they're like, you know what, I love my condition. I've had people say their conditions taught them stuff, but I've never had someone that's like, I love it, it's great, I'm so happy it's here. So it's not that kind of acceptance we're talking about. You don't have to get to a point where you kind of welcome it in, but you have to sort of, or try, we're trying to help people get to a place where they allow it to be. So it's more about allowing than being like, yeah, come on. But we do a bit of the yeah, come on to try and help you get to that place. And then there's support and treatment for comorbid anxiety, depression, other mental health difficulties. Again, there's just that interplay between physical stuff and mental health stuff. If you're struggling with anxiety and depression, probably you're going to experience that in your body as well. Okay. Sorry, I'm aware of the time. I'm talking slower than I anticipated. I haven't got too much longer, don't worry. So I just thought I'd talk about a few different things that are helpful sometimes for people. So mindfulness and breathing. So a lot of therapies, particularly the third wave ones I spoke about, so acceptance and commitment therapy, compassion focused therapy, mindfulness based cognitive therapy, it's in the title, focus on mindfulness and what we kind of call presencing. So anxiety in particular loves to either live in the past and ruminate constantly over things that have happened, or be jumping into the future and predicting and speculating on everything that might be to come. So practicing being more present in the moment, which is the only place we can really affect change at any point in time, can help us be more centered, and it can sort of enhance our well-being. There's a balance to strike. It isn't to say that you need to be deeply present with every difficult symptom you experience and fully feel that, but it's about not letting your mind take you away from each moment. The concept of mindfulness has become a little conflated with meditation, and it's often suggested that the goal of these exercises is to relax. It's kind of true, and I often get people when I do them in sessions being like, oh, that was so relaxing, and I'm like, oh, that wasn't quite what we were going for. So the main goal of mindfulness is to just be present, and sometimes that can be a really active process. So it's about being present in the moment with this kind of openness and curiosity, so just noticing what's happening in that moment. And we know that mindfulness can have a really profound effect, not just on stress management, but on other physical factors, so energy levels. It can lower blood pressure and heart rate. It can improve your blood sugar regulation. So we know it's a really beneficial thing. We know it's affecting the good parts of the nervous system that we want to be affecting. So, a couple of different examples of the way you can do it. So just drawing attention to your breath is a really good one, and it's one you can do anywhere, anytime. Not even necessarily trying to change it, just noticing, where am I feeling my breath? I know I think you've had a webinar on breathing that's fantastic. I watched it, it's great. So thinking about those exercises, just drawing attention to your breath. Where am I feeling this? How am I doing today? And then other breathing exercises that I do is kind of soothing rhythm breathing or square breathing. So that's what this diagram here is. And the idea of these exercises isn't necessarily to take deeper breaths, it's to slow your breath down. So you kind of start here and you breathe in for 4, hold it for 4, out for 4, hold it for 4. And if you're someone that finds that ratio too much, and I will put my hand up and say I get really dizzy doing 4, 4, 4, 4. But for some people, that's perfect. So you can change it, and you can change breathe in for 3, breathe out for 2. So you can change it to a ratio that works for you. Ideally, you want your out to be a bit longer than your in. But yeah, it's just about tweaking what feels comfortable for you. But anything that just slows that breathing down a little bit. So we're not trying to take really deep breaths. It's just taking kind of slower breaths. And then focusing your attention fully on an activity. This is the more active side of mindfulness that I was saying. So this can be anything. You can do it with cooking, brushing your teeth, anything really every day. And just going into that and saying, right, today I'm going to focus my full attention on this activity. And I guarantee that you will notice things that you've never noticed when you've been doing that before. And I'm not saying that from my experience, I'm saying that from lots of different people's experience. It can be a really good one to do with eating. So when we do mindfulness groups where I work, and we often do it with eating raisins or chocolate, and just really absorbing yourself in that. What does it smell like? What does it taste like? What can you hear? What can you feel? Tapping into all the different senses just means that when you're fully present in that moment, you notice so much more. And then the last one I've just put, people might be familiar with already, is grounding activities. And again, I like to imagine, if you imagine like a plant and they're grounding, so you're pushing yourself down, you're holding yourself and anchoring yourself to the present moment. So there's lots of different ways you can do this. A really easy one to just do on the fly is name 5 things you can see, hear, touch, taste, or smell. If that feels too difficult, I sometimes get people being like, I can't taste 5 things. Do 5 you can see, 4 you can hear, 3 you can touch, 2 you can taste, and 1 you can smell. So just picture your hands when you're doing it. And counting out those in whatever environment you're in can be really helpful. And these are things you can do when you're feeling completely fine. They're things you can do when you notice your symptoms of feeling like they're creeping up on you. And the things you can do when you notice anxiety is a bit higher than normal, for example. So they work in lots of different situations, but the way that they work is really calming down the nervous system and just making you feel more present in this moment. And one area we focus on a lot in acceptance and commitment therapy, or ACT, you might have heard it referred to as, is values. So values are the things that you really care about, really deep down inside, and they represent what you want your life to stand for. They frame how you want to behave on an ongoing basis, and they give your life meaning and purpose. They're a bit like a compass. We always kind of picture it like a compass. They guide you out to the direction that you want your life to go in. And we might pass landmarks on the way, maybe a hill or a town or a mountain, and they're like the goals. So we might arrive at those things, you might achieve a goal, but you never arrive at the value direction. So I sometimes say, if you picture it, the value is the horizon. So you might be in a boat traveling along and you're picking up different things on the way, and they're your goals and they're things you can achieve and you can tick off your list. But the horizon never changes. It's always something you're moving towards. It's always the direction you're going in. And our track might waver from that direction that the compass is guiding us in. We might feel a bit lost and confused. And that can be particularly true after a medical diagnosis or a change in your condition. It can feel like that really shakes the direction that you're moving in, and you can suddenly feel very disconnected from your values. But always coming back to that compass, coming back to what that means for you, can help guide you in the right direction. And it can be really helpful to think through what your values are, what's important to you. Identifying them and clarifying them helps, because it provides the motivation to deal with the difficult things in life. So I always had, like, a value for me when I was younger was always to do sort of well in education, and I knew I wanted to be a psychologist. I knew that was a goal, but it was more about getting to a place where I could try and help people and affect change. I really wanted to work in that environment. And all of the difficult stuff along the way, like A-levels and uni and a doctorate, were horrible, especially the doctorate, really, really difficult. But if you have that value, it gives you that motivation to struggle through the things that are a bit more difficult. And there's lots of different examples as well. I'm not going to use loads of my clients' examples because I haven't got their consent to do it, but I've had people say just different ways that you have to go through difficulties when you're managing illnesses. If you've got a value that you're working towards, it gives you that motivation to push through something being more difficult. Values can cover a whole range of areas. So family, work, leisure, you name it, you can make a value around it. There's different, there's an app, there's a values card sort app you can do that I've done in sessions with clients. If anyone wants a copy of a values card sort, drop me an email. I'm happy to send you it. We do them in sessions all the time. They're so interesting. I do them all every now and again just to see where my values are at. And it's just a really interesting way of trying to work out what's important for you. And another thing we often say is our values are like continents on the globe of the world. So no matter how fast you spin that globe, you can never see all those continents at once. There's always some at the front and there's always some at the back. So from moment to moment, you get to choose which ones are at the front, which ones are at the back. And it's the same with your values. So you have values on loads of different things. You can never be working towards everything at once. So it's up to you whether you prioritize this thing for now and this thing for later. Once you're more aware of the values and which ones you want to prioritize, you can always choose to do something that's edging in that direction, even if it feels like you're only taking small steps. And sometimes once people have been diagnosed with an illness, we have to change how we're moving towards that. And that's okay. We can be creative in the ways that we serve our values. But once we know what they are, it gives us more of a path to work towards them. And if you're kind of struggling with that acceptance and that adjustment around your health, it can be really easy to give up on a lot of your values to avoid facing that difficult feeling that comes from not being able to kind of move towards them in the way that we always have. But we often find kind of working through that and finding ways to be more willing to open up to it and accept the situation can help you then reconnect with that value, even if it is in a different way. So yeah, that's something, that's a big thing that I do in sessions with clients that's hopefully helpful. And then the last thing we're going to talk about is something called clean pain versus dirty pain. It's also kind of sometimes natural pain versus unnatural pain. And nobody likes pain, so it's really normal to try and avoid it, but there is natural pain in life that we can't avoid. And clean pain is what you experience when something intrinsically hurtful or stressful happens to you. So clean pain comes from the things we can't control, such as the symptoms we experience from PoTS or just being diagnosed with PoTS. dirty pain or unnatural pain stems not from an objective situation or event, but from your subjective thoughts and feelings about that situation or event, whether that's real or something your brain is telling you. For example, for me, lights, I have one of the offices I work in, the clinic room, has really fluorescent lights, and it almost always triggers migraines for me. And as soon as I'm in that office and I start to get a slight pain behind my eyes, I can hear my thoughts just fly into overdrive that that's going to write out my day. I'm going to be a useless psychologist by the end of the day because I'm going to be in too much pain. I'm going to feel sick. That's my evening written off. I'm not going to be able to make dinner. And I can feel them start to run away with me. And I even get to the point where I'm like, maybe I'm going to have to cancel my clients tomorrow. And at that point, my migraine hasn't even started. I've had a tiny twinge of pain. I can turn the lights off. I can move to a different room. I can do something about it. All of that thought and that struggle and the stress that's coming from that is what we would term dirty pain. So that is my brain basically just torturing me and causing me loads of stress for something that hasn't actually even started to happen yet. And our brains are really good at that. We're a very evolved species, and that is a good thing in a million different ways, but our brains have evolved to problem solve constantly. And so they will always be thinking about ways to do that. So we don't have a lot of choice with the clean pain, clean discomfort. But when you fight that clean pain and that you can't avoid, it hurts more and it tends to cause more suffering. So pain plus resistance tends to equal suffering. So dirty pain can also come as a result of trying to push away our emotions. Going back to our beach ball, over the years, our culture's kind of determined that certain emotions are bad or unwanted, and we have to be happy at all times, which isn't realistic. Even kind of the medical way of looking at it, like any negative emotions are pathological. Actually, a lot of it is just sitting with the difficult feelings, which are part of life. And a lot of what I go through in sessions with clients is we want to get to the place where we can sit with the clean pain and, again, accept or tolerate it, have a willingness to sit with it, to try and mean that it causes less of the dirty pain. So the clean pain we can't change. I can't take away the fact you have PoTS. I can't take away the symptoms that brings. We can do everything you can to manage it, and usually it still means you have symptoms anyway. But what we can affect is the way that you feel in those moments. We can affect that dirty pain. And again, it comes back to this concept of feeling is healing. Allowing those feelings to be present can usually be quite a powerful thing. Often in most illnesses, railing against the condition and constantly fighting it tends to cause more of a struggle. So it's all about being able to develop a tolerance. I use the word tolerance because I think it is more fitting than acceptance, but a tolerance to sit with the difficulties that it brings. And I appreciate this is easier said than done. I've just given you a really good example of how I am not so good at this and I can cause myself a ton of dirty pain, but it's a process and it's a journey. And just being able to start to recognize, am I in a clean pain cycle here or is this switched over, is really good to start. And it can be something that you can work on with a psychologist or in other situations. And then the last thing I just had was sources of support. You might know a lot of these, and I know the PoTS website has tons more than I could fit on a slide, so definitely go there. But your GP can be a great source of support, particularly if you have a good relationship with them. They can talk about local IAP services and referring to NHS psychologists. Most IAP services have long-term conditions groups or sections of them. Seeking therapy privately is another option. Practitioner psychologists, so clinical psychologists, should be registered with the Healthcare Professionals Council. You can search on their register. And then I just put some places that you can find psychologists. And then in more urgent situations, Samaritans is a great place to phone. You can phone them for free at any time from any phone or email. The email response is usually about 24 hours. Shout is a slightly newer service, but it's text. So I know some people prefer just to communicate that way when they're really struggling. So you can text them, again, it's 24/7. And in an emergency, 999 111 or attend A&E. And that's it. That's the end of my slides. Thank you very much. I'm going to stop sharing now. No, I'm not. I don't know how.
Thank you so much. I think that was Absolutely fascinating. You know, so many things, like you're saying, even just being, if nobody took this any further than this evening, I think just knowing those things. So the example of the clean and dirty pain, I can think of so many times where I will talk to myself with something, and just being able to refer back to what you said and thought, okay, I can see what I'm doing here, just gives you that power, doesn't it, to try and stop it. So really, really fascinating. Thank you so much. So yeah, feel free everyone to pop questions into the Q&A box. We've had some already, so I'll go through these. So we'll start with, do you see a relationship between PoTS and psychological trauma?
Yeah, there can be. I think it can be really individual. I think it's an interesting one. I don't know exactly what you mean with your question. So there's some research that suggests PoTS can come from trauma. So there's some examples, I think there's case studies, and there's also bigger studies that suggest people can develop PoTS after experiencing trauma. So there's definitely a relationship in that respect. Again, it's such an under-researched area. I know I sound like a broken record constantly saying that, but I know when I did research in this area, it's difficult because there's not a lot out there. But there definitely seems to be a link, and similarly bodily trauma as well. So people can develop PoTS after surgery. That can be quite a common one. But also I think having PoTS can come with a lot of trauma. I know some people find all the different medical investigations you have to undergo, or people have undergone to rule out lots of other conditions. I know sometimes I've worked with people where that's been really traumatic for them, and actually getting even to the place of a diagnosis feels like a relief, but then it's being able to work through the medical trauma that's come from that. So that can be another one as well. Sorry, I don't think I may have missed your question, so if I have, let me know and I'll try and answer it better.
I mean, obviously I didn't ask the question, but I think that sounds, that certainly seems to have answered it. Do you know of any support groups or websites for PoTS or chronic pain?
I mean, you may do some support groups.
Yeah, shall I advertise that? So yeah, we've recently started peer support groups. You can join a regional group, and they're all online via Zoom, or we've just started, just in response to feedback, because they tend to be evening groups, we're starting some afternoon groups that's open to anybody. It doesn't kind of matter kind of geographically where you are. So all that information is on our website and quite heavily advertised on our social media. Are there any others that you're aware of that you would recommend? Or
I mean, there's therapy groups through stuff like IACT, but that's quite different from a support group where the purpose isn't therapeutic. I know I've worked with people who have used like Facebook groups or Reddit groups. They're not ones that I'm familiar with, but I know sometimes people seek support. It's often just that sense of, oh, this is normal, this is okay, other people experience this. So I know online kind of Facebook social media groups can be helpful for that. Equally, I know they can sometimes feel a bit overwhelming. I know I've had people say actually being in those spaces is too much for me. It's either difficult seeing people in flare-ups when I'm not, or difficult feeling really just overwhelmed by the symptoms. So yeah, I think support groups like the ones PoTS are running that are a bit more self-contained can sometimes feel more helpful, but it's complete personal preference.
That's great, thank you. And yeah, and what I would say is, I mean, the feedback that we are getting is just, the most common one is, it's so nice to speak to other people with PoTS, because I think you're not meeting people in your everyday life who've got it. And so I think just feeling, you know, like what you're saying is validated, and how you're feeling and everything. I think it's, they've been really powerful. It's been amazing to see them get up and running. And there's no obligation to attend monthly or anything. You can just drop in as and when you need them. So yeah, definitely give it a go. This is quite a long question, so bear with me. So regarding cognition, I've just started taking Ritalin. This person's tuning in from Australia, so not sure if it has the same name in the UK.
It does.
Yeah, and I've found considerably positive changes in cognition from taking this drug. However, I'm aware of almost the inevitability of tolerance, and my threshold will continue to increase and the drug will become redundant. Have you worked with anyone on an ongoing basis who are prescribed this medication? Wondering about experiences of people navigating these medications, reaching their use-by date, and how patients cope, whether their cognition is still at a functional level following this medical intervention, reaching its threshold, or whether individuals go downhill and it's a cycle of individuals going up and down, tapering on and off the different medications. So it's quite a wordy question. Are you?
So I think I'll caveat. So I don't prescribe and I don't manage medication. So I know Ritalin is sometimes prescribed. It's in England, it's used mainly for people with ADHD, so it can focus people's attention. I think it's, if you're worried about it getting to a place where you're tolerating it and then you're needing more to have the same effect, it's worth speaking to your doctor about it. I realise that sounds like a bit of a cop-out. It's mainly because I don't do the medication side of things. I have worked with people who take those medications and see them as beneficial. I don't know that I'm trying to think if I've worked with people who have had that kind of cycle, and I'm not sure that I have. I mean, when I work with people with cognitive difficulties, it's often from quite a different angle. So we're looking at strategies they can put in place to manage the difficulties and scaffold them, rather than medication. But again, that's mainly because I don't prescribe. I think it's definitely something worth speaking to your medical professional. I was going to say GP, but if you're from Australia, I don't know if you have GPs. But speaking to whoever prescribed them and saying that you're noticing that kind of pattern, and is there anything else they can recommend, and looking into other strategies to manage the attentional difficulties.
Yeah, that's brilliant. Thank you. And I think from the charity's point of view, we'd always say the same, like whenever we get asked questions about medications kind of in a group situation, it's always so hard because it's so individual to everyone. But for the person who asked that question, we do have a mailbox. It's support@potsuk.org. And you could certainly ask that same question of them and just see whether the team have sort of any, Ritalin's not, I'm not a healthcare professional. I don't get involved in any of that side of things, but that's not something that I've heard about when I've been speaking to people used with PoTS. But if you email that email address, there's a good chance that they'll have a bit more information and might be able to give you a bit more of a steer as well. So that's another resource there. I think you've covered this one, but just in case there's anything further you wanted to add, how can you access professionals with the appropriate understanding of PoTS and overlapping conditions? So my 20-year-old was told to self-refer to Time to Talk, but she's not happy to talk to someone who doesn't understand her chronic issues. So it's easy to go out, well, it's not easy to go out, but it's one thing to go out and access support for this, but trying to find somebody who actually understands it is another battle. So is there any tips that you'd give people for that?
I think asking, so Time to Talk, I think, is probably an IAP service. And I think asking when she has an initial assessment, which they always do in these services, whether there's anyone in that service that understands those conditions and has experience of working with them. Like I said, most IAP services now have a long-term conditions arm. So they do groups for people with different chronic conditions, albeit they're varied. So it wouldn't necessarily be, as far as I'm aware, that there's services that have PoTS groups, for example, but they would be other people with different chronic illnesses that might overlap with the things your daughter's experiencing. Sorry, I've said daughter and just completely assumed it's a girl. That's bad, isn't it? I think you just said their age.
Yeah.
Your child is experiencing. So I think asking, it's really tricky. It's easier to do it privately because you can see what the therapist works, and it's harder on the NHS because you don't have the same flexibility. But it's definitely worth, if she's self-referring to a service like that, saying, these are the conditions that I have. I want to speak to someone who understands them. Do you have anyone that knows a bit about them? And you might find that they do. I know with the kind of rise in long COVID, that's something that is kind of spreading the awareness a little bit of things like PoTS. So I know that there are psychologists that are learning a bit more about it through those avenues. So it might be that, I'm not sure where you're based, so I don't know your service, but IAP services all over the country are slightly different. It might be that they've got someone that does actually know quite a lot about that, and they could kind of triage the referral that way. So it's always worth just seeing if she could ask when she has that initial appointment. Because I think the thing with therapy and therapists in general is, like, this makes me sound like I'm doing my job a disservice, but a lot of it is the relationship you have with the person. Like, obviously you want them to be skilled and well educated and well trained, but so much of it's about the relationship you have with that person. So I think if she can say from the outset, actually, this is something that's really important for me to feel comfortable and to build that relationship, I'm sure if they have someone that can offer that, they'll try and help.
Absolutely. No, really good advice. Thank you. Well, I've lost the question. Now, here it is. So I'm not sure if this is something that you'd want to cover tonight, but I'll ask it just in case. My daughter has asked me to ask, with a neurology, with your neurology experience hat on, is there anything you know that can help with the neurological type symptoms when there is too much adrenaline going on, which creates tics? So I don't know if...
I don't know tons about it, to be honest. I haven't worked in tic disorders. I know that there's a whole specialist area that's working with that group. I know massive adrenaline dumps can cause lots of symptoms. So I don't know tons about tics, but about kind of shivering and shaking. And sometimes in people, it can cause dissociative seizures. And I think in terms of, is there anything that can help? I think a lot of the stuff we've spoken about this evening will help in some respects. So it will help because it helps calm the nervous system when you notice those huge floods of adrenaline, and it can help because often what we see in those situations, when you get flooded with adrenaline, you go straight into fight or flight or flop or freeze, and it can be really difficult to then break out of that cycle. So using things like grounding and presencing tools can be a good way to help you come back to this moment and kind of feel more present. I don't know how much that would help with tics. I'm really sorry, I don't know loads about tics specifically, but I imagine it would work similarly. So using the same kind of nervous system calming approaches that we would use with someone who's got anxiety or someone who's experiencing those massive jumps of adrenaline that do make you feel so unwell. So it's about balancing. We know you're feeling really unwell, but let's try these strategies anyway. And what I often say with these strategies is they're probably not going to hurt. So they're usually worth giving a go. So it might be worth trying some stuff like that when you notice that it's happening and see if it helps. Otherwise, I would say speak to a medical professional and or a psychologist who would probably be able to help more.
Okay. Brilliant. Well, I think in view of the time, I think we'll leave it there. I think there's a comment here that just says, no question, just a thank you for this webinar. It's very validating to hear that all the things I experience and go through are very typical for those with PoTS and chronic illness. And I'm imagining that that's something that lots of people are feeling. And when people watch this back on YouTube, will also feel. So I think it was a really fascinating and interesting and validating time, and really genuinely grateful. It's like we're delighted to have you as a medical advisor at PoTS UK, and hopefully this will go a long way in helping people feel reassured and validated in how they're feeling. So thank you so much.
No, thank you for having me. It's been so lovely.
Is there anything else you wanted to add or anything at this stage?
I don't think so. No,
okay.
I hope you answered questions enough. If not, get in touch and we can try and help a bit more.
Absolutely. So I will, I'll make sure I save the questions, and if we haven't covered any, we'll aim to do that after the session, and it will be up on YouTube in the next couple of days. But thanks everybody for attending, and we'll see you all soon. Thanks a lot.